As I was praying, what needs to be done more in the ministry? And now that the Lord has given us the new facility, in what way we can go forward? In what way we had to, change the direction of the ministry or improve the ministry? What way we can get the benefit? The congregation, the Lord's people will get benefit. This was there on my heart, and I started praying, and Sunita and I, we've been praying much. At the time, Lord has given a thought about the physical health also for all of us. As an expats or as a people that are away from our families, we have this constant stress. మన హృదయాలలో ఆ కాన్స్టెంట్ స్ట్రెస్ మనం గురవుతూ ఉంటాం. Recently, I heard so many bad news that people, young people in their 30s and 40s, all of a sudden, they're just going away. And this all started 3 years ago when God called my own brother, younger one, 45 years. All of a sudden, I received a phone call that he's no more. And we came to know it is a cardiac arrest. Then I came back and I started asking my cardiologist at the time, Dr. Loam, Dr. Stephen Loam. At the time I was asking why there is no alert signal, no symptoms, nothing at all. And then he mentioned that for every one person in 3, the first symptom is death, especially when it comes to the heart-related issues. Then I started, అలాగైతే చాలామంది ఇప్పుడు యంగ్ పీపుల్, ఏజ్ nowadays is just a number. I saw some people in 20s, I saw some people in their 30s, they just, cannot take it, the stress or bad lifestyle, it doesn't matter. All of a sudden they're gone. They're here one day and they're gone the other day. So what benefits the Lord's people? I was asking and praying. Then the thought came. I went to my cardiologist, Dr. Shah, and I started talking with him. We have a church, predominantly IT people. There are some in nursing and medical profession, but predominantly we are IT people, and there is a lot of stress. What can be done? Is there any way that you have some kind of a community event? Adiginappudu, then he said, I can come to your church, but I have a better person. And he sent Dr. Sharubjeet Singh. Why? Because Dr. Sharubjeet Singh, he's a cardiologist, intervention cardiologist. That's one thing professionally. But more importantly, he's a professing believer. He's a born-again believer. His parents, they came to know the truth, and they converted from Sikhism. And he came here. He's born in India, by Jalandhar. He said he's born in Jammu, Kashmir, and then grew up in Punjab. At the age of 7 or 8, they migrated to US, and he grew up from there in New York area. He moved here recently for the job, and then Dr. Shah, my cardiologist, said, he is a Christian. Maybe he can serve you, he can help you better in these things. So, long story short, it happened after 3-4 months. The day has finally arrived. So today I just want to mention one thing. The book of Proverbs chapter 4 verse 23 says, guard your heart, for out of it are the issues of life. I'm talking about spiritual heart. తెలుగులో అయితే చక్కగా ఉంది. ఒకటి గుండె అంటే గుండు కాదు, గుండె అంటే physical heart, హృదయం. There are 2 different words properly written for us in Telugu. కానీ ఇంగ్లీష్కి వచ్చేటప్పటికి it's all one word, heart. So we need to differentiate between physical and spiritual heart. The Bible mentions you need to guard your heart, because out of it are the issues of life. Now, if you take that word spiritually, we all know how much important it is for us to guard our hearts. Man has 3 parts: body, soul, and spirit. Body, soul, and spirit. That is human being. Body, soul, and spirit. I'm not talking about body. Doctor will come and talk about body part. Spirit, we all know, and we can't understand the mysterious being of the spirit part. But there is something called soul. In soul, we have mind and heart faculties. Every human being, in their soul, they have mind part and then they have a heart part. Mind part is telling, intelligence, logic, a plus b whole square is equal to a square plus 2ab plus b square. 1 plus 1 is equal to 2. If I do this, what will happen? Mind is about thinking. Mind is about intelligence. Mind is about getting different thoughts, but those thoughts, when they're mixed with emotions and will, that's where the faculty of the heart comes. ఆలోచనలు రావటము ప్రాబ్లం కాదు. శత్రువైన సైతానుడు ప్రభువులో కూడా ఆలోచనలు పెట్టాడు. ఇగో నువ్వు నాకు మొక్కు, ఈ రాజ్యాన్నంతా నీకు ఇచ్చేస్తాను, భూమిలో ఉన్న సకల సంపదలు నీకు ఇచ్చేస్తాను. ఆల్ యూ హ్యావ్ టు డూ ఇస్ వర్షిప్ మీ. థాట్స్ విల్ కమ్ ఫ్రమ్ సో మెనీ డిఫరెంట్ వేస్. బాగా ఆకలేస్తుంది అనుకోండి, మనకి బాడీ విల్ ట్రిగ్గర్, ఒక థాట్ ట్రిగ్గర్ చేస్తుంది. ఏంటంటే, అరే మాథ్యూ నీకు ఆకలేస్తుంది, మంచి ఫుడ్ తిను. లేదు, మనం బయటికి డ్రైవ్ చేస్తూ ఉంటాము, మెక్డానల్డ్స్ కనపడుతుంది. ఆకలి లేకపోయినా సరే ఒకసారి ఒక థాట్ కొట్టుద్ది మనకి. కొట్టుద్దా? మెక్డానల్డ్స్ కొట్టదేమో కదా. యా, ఇలాగ different triggers, are there in our mind that will provoke thoughts. But thoughts will not make us bad. It is our heart that either will make us bad or good, because there the decision making happens. మైండ్ పంపిస్తుంది. ఇప్పుడు మైండ్కి వెళ్ళిన తర్వాత నా హార్ట్ పనిచేయడం మొదలు పెడుతుంది అనమాట. వాట్ ఐ నీడ్ టు డూ? షుడ్ ఐ స్టాప్ ఫర్ అ బర్గర్ ఆర్ షుడ్ ఐ మూవ్ ఆన్? ఐమ్ ఐ రియలీ హంగ్రీ? Now I will bring some kind of logic. I'll bring some kind of intuition. I'll bring some kind of standards. And then I will decide whether I need to do it or not. Whether I need to obey or not. Whether I need to take my body there or not. It's all in the heart. That's why the Bible says, guard your hearts. That is my spiritual thing that I was about to say. Now, how is your heart today? గుండె కాదండి. గుండెకి డాక్టర్ గారు వచ్చి చెప్తారు, మీ హృదయం ఎలా ఉన్నది ఈరోజు? కలవరంగా ఉన్నదా? సౌండ్ డెసిషన్స్ తీసుకునే హృదయంగా ఉన్నదా? ఎందుకనంటే ప్రభువు మన హృదయంలో నుంచి వచ్చిన ప్రతి ఆలోచనని ఒకరోజు జడ్జ్ చేస్తాడు. మైండ్లో వచ్చిన ఆలోచన కాదు నేను చెప్పేది. మన హృదయంలో నుంచి వచ్చే ప్రతి డెసిషన్, ప్రతి విల్, గాడ్ విల్ జడ్జ్ వన్ డే. హౌ ఈజ్ యువర్ హార్ట్ టుడే? How to take care of your heart, guard your heart, physical heart. Let's invite Dr. Sharubjeet Singh and his family. He will introduce his wife for us. Yeah, with a big hand, with a big hand. Yeah, come on. Yeah.
All right, well, thank you for having us. I think the pastor's done a wonderful job introducing me already. So my name is Sharubjeet Singh. I am an interventional cardiologist at Rush Copley. This is my beautiful wife, Mary, and this is our super cute son, Joshua Charles Singh. He's going to give most of the talk.
He's busy.
He's busy.
Yeah. You want one stand? Yeah. Okay. Oh no, later. That's okay. Sorry. That's okay. Doctor is, he will take the questions also. So if you have any questions, if it is a personal history, he's still ready to answer. So meekunna jabulu edanna unte questions unna, he can discuss after. Yeah. After this service also, he will be here, and if you want to talk with him. Once again, thank you so much, doctor. Thank you so much for coming and spending time. Now, take care of your heart.
Yes.
Physical.
All righty. Well, good morning to everyone. Again, thank you for setting this up, Pastor Matthew, and for the wonderful service this morning. I do have a bit of a visual aid. I think there's a PowerPoint. Honestly, at first, I thought I was going to just do mostly speaking, but After Pastor Matthew told me that there's a lot of IT folks, I figure I step up my game here. So, so again, it's mostly going to be a visual aid, just so we have something to take a look at as I'm speaking. But just to give you a little bit of background on myself, adding on to what Pastor Matthew said, I was born in India, came here when I was 8, did all my schooling in New York, and then up to my bachelor's, and went to Windsor University for medical school, and subsequently ended up in Chicago. I did my training in general medicine, cardiology, and interventional cardiology at Mount Sinai Hospital through Chicago Medical School. And I joined the practice over at Rush Copley November, replacing another physician who was retiring. And yeah, Dr. Shah was the one who connected me and Pastor Matthew, given that we're cardiologists and we're in the faith, so he figured it would make more sense for me to do this instead of him. So I think if you can go to the next slide for me. Okay. I think the easiest way that I want to do this is, the whole point of this is, again, not for you guys to get an in-depth pathophysiology of what cardiovascular disease is, but just to have a layman's understanding of what it is and some of the signs and symptoms of it, and how, most importantly, how to prevent this. Being from the the southern continent of Asia, all of us, unfortunately, Indians, cardiovascular disease is rampant. And part of it is genetics, part of it is what we eat, and I think we can all speak to that, a little too much samosas once in a while. But there is a big genetic component to all of this, and that's not just in one family, it's kind of a race thing for us. If you look at our counterparts, particularly in Europe, they have other issues that they have to deal with, which we don't, but from a cardiovascular standpoint, we have a lot more of that as compared to them. And one of the other areas is in women, unfortunately, a lot of this, it's been underdiagnosed, particularly in younger women. So as a visual aid, basically what the heart is, the way I like to describe this is in very simple terms, is if you think about your body being a house, and the cardiovascular system is basically the plumbing, and the heart is, an overglorified water pump. But the reason, and as you understand that, is that we all understand if you get a clog in your plumbing, the water flow will decrease, and if you get to a point where there's no flow, well, the pipes can burst, and of course you'll have, major issues with your plumbing, and that is exactly what happens in our body. So if you look at the slide, the heart sits right in the middle of our chest. The heart is interconnected with the lungs, so the heart and lungs work together. And there's a big vessel that comes off the heart, which is called the aorta. Just as soon as it comes off, it gives the branches to the heart itself, which are the arterial vessels that supply oxygenated blood to the heart itself. As you can follow down, it goes down into the legs, feeds all the vital organs, also into the neck, and feeds the brain. So although we're speaking predominantly about the heart here, it's not there's no one particular way that you can modify your risk for just the heart. It's the entire system, which is the vascular system, so it affects everything. It's not just one area. The reason we focus on the heart and the brain are because those are the most valuable areas in our body. So even minimal injury to those or decrease in blood flow, you'll have symptoms. Obviously chest pain, and then leading to a heart attack, and in brain, a stroke. We have those folks who have blockage in the heart, blockage or have had history of strokes. They have some degree of blockage in the legs, as well as the blood vessels that are feeding the other organs. It's just those organs can tolerate it better, and they're not potentially life-threatening. Whereas the heart and brain are, when you have issues, they are, as the pastor mentioned with his brother, these could be minimal symptoms to threatening your life. So, although I do apologize, I don't speak Telugu, but I did understand the media booth joke, so that was pretty good, guys. But again, if I do speak a fair amount of Hindi and Punjabi, so if you guys have, if the older folks have any questions, we can definitely chat at the end about that. So again, just to kind of move forward and get things flowing, we can go to the next slide. So what is cardiovascular disease? From a medical standpoint, what we call is atherosclerosis. Atherosclerosis is basically you have a pipe in our body or in the house, and you have over time clogs that build up. It's basically where and when atherosclerosis occurs in the coronary arteries, we call that coronary artery disease. And it's basically a combination of fat and lipids or cholesterol, which over time build up in your body. Now, there are things that this occurs in all of us. Unfortunately, there's been some data that they looked at even in little ones that atherosclerosis has started building up as early as age 5. Now, again, it doesn't cause any issues until it gets to a certain point. But as you can see, even the little ones, when they're very, very young, they're not really, they're very active. They're not eating anything that's supposedly not, heart healthy. And even then, we start seeing it. So we all will have some degree of this as we get older. But there are risk factors that we can modify that can either help mostly slow it down, or, if we can try, of course, to prevent it. So if you can, and it is this, when you have a blockage, what's considered a significant blockage for us is if it's more than about 70%. So if you have the inner lumen of the artery, and once you get to about that 70% mark, that is when we get concerned that we may need to intervene on it, because at that point is your risk of symptoms, including chest pain, shortness of breath, and of course having a heart attack and subsequently heart failure if you do have a heart attack increase. So that's kind of our cutoff on when we want to intervene on something. We can go on to the next slide. So again, just more of a visual aid. As you can see, the yellow part is the cholesterol and the fat deposits, which is significantly narrowed the inner lumen. Now, understand that all of our organs, including the heart itself, the way it gets its nutrition is through the blood. And if the blood is not, which particularly is oxygen, and if the oxygen is not able to get to the organ because the lumen of the artery is very, very small, you may not have symptoms at rest, but when you start exerting yourself or when you start doing something physical where there's a demand and supply mismatch, you'll get symptoms. Go ahead to the next slide for me. Again, just a bit of a visual aid. So if you look at the top right where it's the atherosclerosis with the blood clot, that basically is, visually speaking, what a heart attack is. So what happens is over time, you get built up of this plaque. And then for whatever reason, the top layer of the atherosclerotic plaque, or what we call as a cap, it's thin. And you have to imagine that there's blood constantly flowing past this lesion. And over time, that cap becomes weak and it ruptures. And that the top part of the cap, or the top part of the plaque, is exposed, and that's when all the platelets come and start trying to manage that plaque. However, it does that by forming a clot. And when that clot forms and it loses complete flow, that's essentially a heart attack. Now, depending on what part of the heart, what part of the vessel, and is it a complete blockage versus a partial blockage with the blood clot, depends on how big the heart attack is. And that's the exact same pathophysiology that occurs in a stroke, particularly in the neck, as well as in the legs. Again, but the scary thing with the heart is that the chance, unfortunately, of life-threatening from the heart is a lot more as compared to legs. And then there is a rare form of what we call coronary artery, which is more spastic. That's more of a genetic component to it. There's actually no actual disease there. It's just the artery spasm, and temporarily you have decreased blood flow. But yeah, just to add the next one. And again, just to kind of give you, the reason I put this in is most of us are born with 3 or 4 vessels of the heart, generally speaking, 2 or 3 on the left circulation, and then 1 on the right circulation. The reason the right one's a bit, although the largest muscle of the heart is supplied by the left circulation, the reason the right one is important, the right one is actually what supplies the SA node, which is the automatic node which controls the electrical activity of the heart. So the heart is one of those organs where it doesn't need any input from the brain. It's able to function on its own independently. And it is this artery that supplies that system. So when you have injury or when you have a heart attack that involves this artery, there are folks that can have electrical issues with the heart. It's a bit different from this particular talk. If you have any questions about it, I can definitely answer, but we'll fly over that for now. All right, we can go to the next one. So just to give you a little bit of epidemiology on this, so cardiovascular disease has been a known risk factor for many years, since the early 1900s. I mean, these are staggering numbers. You have about 2,700 folks that pass away in just the States, not even internationally. I'm sure it's significantly more on a daily basis from this. And cardiovascular death or cardiovascular-related mortality is the number one. And then when you add on the next number 2 to number 6, it still doesn't add up to how many people we lose from a vascular disease, from a cardiovascular standpoint. And as you can see, I think we all have this impression this is a disease of older folks, or hey, grandma had it when she was much, much older, or grandpa had it when he was older. But unfortunately, this is significantly changing. I'm not sure if it's changing or we're more aware of it. I think it was probably there, but particularly back home, it's just, we're not sure why he passed away. He just passed away, or she passed away, rather. So I think there's definitely now that there's more education on there, there's more research on there's more awareness. Even back home, people are realizing that, it wasn't just some unknown thing that the person passed away from, that this is occurring in younger and younger folks. And unfortunately, I've had patients, and it was staggering, where I had a 29-year-old who actually wound up getting a bypass surgery. And, significant family history, both parents, an older sister, maternal aunts, and paternal grandfather with significant disease. So again, if you have the symptoms, you shouldn't just ignore it. I think that's the key here. We can go to the next slide. So signs and symptoms, and again, unfortunately, if you look at the top left, and as Pastor Mathews, family knows that unfortunately, sometimes there are no symptoms. And the first symptom, unfortunately, is death, which is quite unfortunate, and there's not much we can do to prevent that. But again, I think the key here is understanding the family history. If there is something in the family, then it is a reasonable thing to get screenings done early on in life, even though may not be recommended for the general population, but it may be something that's for you as an individual. Of course, chest pain, the most common thing, shortness of breath. And then, sometimes the initial symptom could just be a heart attack, a non-life-threatening, or unfortunately, death can be the first presenting symptom. Okay, I think we can go on to the next one. So again, I'm going to spend a little more time on it. Again, this is very, very simple. I mean, again, what are the causes of cardiovascular disease? Obviously, if you have high blood pressure, high cholesterol, the key here is genetics. Things that we can modify that are non-medical and non-genetics is unfortunately smoking is a big one, obesity, and if you're just not very active. So again, I can give you a list which really doesn't mean much. I think you guys can Wikipedia this or Google this. It is very important to understand what happens in our body what leads to blockage in the blood vessels. So if you look at things like individual risk factors include, of course, the biggest risk factor is genetics. So you have to talk to your older folks, find out what's in the family. And I think, I'm not sure how your family, but I can tell you about my family, it's always like, we have nothing in the family, we're perfect. And no one wants to talk about it, but clearly there have been family members that have had issues. So you have to be, first and foremost, you have to be honest with yourselves and honest with your family that, hey, this runs in the family. Once you know that, then things like high blood pressure and diabetes, what they do is, high blood pressure in itself, fine, your blood pressure staying up. Why would that matter? Your blood sugars are staying up, but why would that matter? Well, the reason it matters is because what happens with that is it causes micro-injury to your blood vessels. Now, this isn't something that occurs one time. This is occurring on a constant basis over decades and decades. And your body, as resilient as it's made, it has ways to regulate that. So it tries fixing these micro-injuries. But again, these are micro-injuries that occur over decades and decades. And when this healing process occurs, that elasticity that's in the blood vessels is lost, because when that repair is made, it's usually repaired with fibrotic tissue, which basically acts like scaffolding to hold the blood vessels in normal position, but it's lost. It's just like a rubber band. If you keep pulling it apart, eventually the recoil goes away. So it's high blood pressure, diabetes, it causes these micro injuries. Smoking, unfortunately, it's not the actual nicotine itself, it's the other stuff that's in smoking or cigarettes that essentially causes micro injury to the blood vessels, particularly to the heart, because when you smoke, the vast majority of the smoke is in the lungs, and the proximity to the heart is significant there. And in some folks, and particularly younger males, smoking has led to what we call peripheral vascular disease, or one of the most common causes of peripheral vascular disease, which is basically significant blocks in the blood vessels where it hinders your exercise and capacity. And then there is cholesterol. Now, if there was one thing that I can tell you that if you should modify that will decrease your risk of overall cardiovascular risk, is cholesterol. And I know there's, depending on what your chain of thought is, I know there's a few nurses and physicians here, I'm sure they'll agree with me on this. There's a lot of data you can get online, and I think vast majority, I don't think anyone's trying to really, fool anyone. It's just sometimes there's a misinterpretation of it. So that we have, when you look at a lipid panel, we have our total cholesterol, which is basically good and bad, and there's a third category, which is basically doesn't fall in the other two categories. Generally speaking, we want your total cholesterol under 200. And as you break it down, then we have something called HDL, which is the good cholesterol. So the higher, the better. How do you get your HDL to go up? One, there's some people are just fortunate; they have a genetic component of having high HDL, but that's not most of us. Most of us, the way you do that actually is with exercise. So physical activity makes your HDL go up. And then there's LDL. LDL is the bad stuff. Okay, that's the one thing. That is the actual fatty tissue. That's the actual stuff that actually makes the plaques. So that once blood pressure, diabetes, smoking, obviously genetic component has over time caused micro injury to your blood vessels, it's the cholesterol that's floating in your body or in your blood vessel which starts sticking to the wall and making these plaques. So again, the less you have of it, the less it's going to have, the less will stick. So with the LDL, right now, the ACC and AHA guidelines recommend that in someone who is at average risk for cardiovascular disease, you want your LDL less than 130, okay? Now, to be frankly honest with you, I think that's a high number. I think we should aim for even lower than that, because if you bought a brand new house today and the plumber comes and he says, listen, if you put this Drano down this drain once a month, you'll never get a block, right? Who in here wouldn't do that? Everyone will do that, because one, you want to protect the house, you put in, this is an investment you made. Two, why deal with blockages later on? So why don't we do that for our own body? A lot of us, I think, including my own parents, are very hesitant on starting medications when there's clear signs, but we would do all these things for our property, but sometimes we don't take care of our bodies the way we should. So I think if we can get these LDL levels, the lower the better. Of course, once you have an established cardiovascular risk, it's actually recommended to get the LDL lower than 70. Okay, we have tons and tons of medications for that, including oral injections, lifestyle modifications, of course, that will help decrease that risk. So as you can imagine now, someone who is older, which is the more common, of course, cardiovascular disease usually is diagnosed 50s, 60s, in that general range. Again, like I said, it takes a long time to build up. So in your 20s and 30s and 40s, it's already building up. So, we have risk factors such as genetics, smoking, high blood pressure, diabetes, high cholesterol. If you add on things like smoking, if you're heavier, unfortunately, and you're not very, very active, well, all of this just accelerates that process. So once you get to that point, then once you already have established diagnosis of cardiovascular disease, then there are, protocols that we have kind of built on how we manage that. So, but again, this is more, from this talk, it's more of just kind of just a heart-healthy kind of information. So we can talk about the medications, of course, in a bit, but just to move on a little bit, if we can go to the next slide. So all of us, again, we should at least see a physician at least once a year. Even as kids, we see the pediatrician once a year. As you get older and you have some established medical problems, and of course you see them more often, and it becomes somewhat complex because then you have to see various specialists as well. Because unfortunately, when one organ gets affected, it's not just an isolated thing. It starts affecting everything else. If you can imagine, if the heart is not pumping very well because it's not getting enough flow, so it loses strength, well, it's not able to pump the blood to the rest of the vital organs. Well, the kidneys are getting less blood, so they're going to be injured. The liver is getting less blood. It's going to be injured. Your brain, your eyes, so everything gets affected. So it's not just, oh, it's just my heart. It unfortunately affects the entire body. So, when you go to your doctor, there's kind of like what we call basic labs or standard tests that we always kind of check. And there's a reason we do these because, if you have an abnormality on these, we can pick up vast majority of things. I mean, there are, of course, rare, sporadic things that, these will miss, but that's not what this talk is about. This is more of, how do we manage kind of as a congregation, not as an individual person sometimes. So as far as blood tests are concerned, you get a CBC, which is basically a blood count. It tells you what your total blood counts are, if you're anemic. A CMP, it basically is what looks at all the electrolytes, the kidney function, liver function, and the protein levels in your body. Of those up there, then the lipid panel and A1C are the two important ones from a vascular standpoint. So the lipid panel, of course, as I described, that will tell us, where your cholesterol level is, where is the LDL. And then the A1C is what checks for diabetes. Okay, if those of you want to know, A1C of less than 6.5, that's considered non-diabetic. From 5.7 to 6.4, you're pre-diabetic, so really you want to be under that 5.5 to not have to deal with that. And then further testing, if needed, of course, is an echocardiogram. An echocardiogram, I think the women here would have or the moms would know, is when you were pregnant with the baby, when they look at the baby, it's basically the exact same tool. Instead of looking at the baby, we put the ultrasound on the heart, and what we look at is we look at the global function of the heart, we look at the valves, and based on that, we can tell, how the overall heart function is. And this is different from the blood flow. The blood flow, you can have decreased blood flow, you can have atherosclerosis or coronary arteries and still have a normal functioning heart. It is when you have a heart attack that you will lose that function. So the key here is to maintain that the heart function. Because you can have coronary artery disease, we can take care of the coronary artery disease, but if you lose the function of the heart, so if you wait till you have the heart attack, unfortunately, there is, some folks, when we open up the flow, the heart function does return, but that's not a guarantee. And then, I would say vast majority of the folks will have some degree of permanent damage. And that's devastating in the brain. I mean, that's a stroke. So you lose that part of that brain, and there's no way to revascularize that. So that's what the echocardiogram is. And then, say you come in and you're like, hey, doc, I'm having these symptoms. And then, we go through your risk factors, and you have some risk factors. One way we can test whether or not you have global ischemia is to do a stress test. We have various different kinds of stress tests. The most simple one is where you come into the office, and we get you running on a treadmill. We look at the electrical activity, and it's on your own power. And the good thing with this is not only do we get to see if there's any electrical changes when you're exercising, but also look at your functional capacity. Meaning, I can tell if you're lazy or not. So you can't lie to me, all right? And then there's a bit more of a sophisticated test, although very simple, is called the coronary calcium score. A coronary calcium score is a very a low radiation CAT scan that we offer. And what it does is it's just a snapshot. It's equivocal to you walking into your basement, opening the door to your boiler room and going, oh, look, the pipes have some rusting on it. That's all it is, okay? Because we presume if the pipes have rusting on the outside, there's some degree of rusting on the inside. So all we do is we take it's basically a sophisticated X-ray. We take multiple X-rays, and we can look at this to see if the coronary vessels have calcium on them. There's a certain score, and if basically less than 100 is low risk, less than 200 is moderate, and then over 300 is high risk. And it was studied, and it showed the higher coronary calcium scoring you have, the more likelihood that you may have some underlying CAD or coronary artery disease. Now, it doesn't mean it has to be obstructive, but if we don't manage it, it can get to that level, okay? And then the gold standard, or the most invasive, the test that we do, or the procedure that we do when, unfortunately, someone's having a heart attack or we have to put some stents, is the coronary angiogram. As an interventional cardiologist, this is kind of where my bread and butter is. A coronary angiogram, it is an invasive procedure for anyone who's had it. They can speak to it as well. But it's not a surgery. We don't cut. Those are the surgeons who do that. We pick a site, usually either the wrist, the right wrist, or one of the femoral arteries. And we basically use, if you recall the first picture, we just use the same blood vessels to go back up to the heart. And so we pick either the right wrist or the femoral arteries. And as you can see, it's, there's a perfect kind of highway. We have catheters that go on, will float up to the heart. And then we can inject into the individual blood vessels of the heart and take a look, and we can find out where the blockage is, if there are any. Okay, so we can go ahead. So that's what the angiogram is. We can go to the next one as well. Okay. So again, I know the vast majority of vascular disease can be, let me repeat that. There is nothing that you have that we cannot manage. We can manage everything. It's just you have to get to us. Okay, and that's very important. Is I think there's some degree of fear, like, oh, what are they going to tell me when I get there? Whatever you have is what you have, and if you don't intervene sooner than later, eventually it's going to get to a point where it's going to cause some negative event in your life, and you would want to get to us, or you want to get this managed before anything negative happens, i.e. a heart attack or stroke. So lifestyle modifications is a must. You have to think differently. You have to understand your own. You have to participate in your own health. No matter what I say, if you don't take anything away from this, just remember that vast majority of that things that we do is dependent on you. So I can write all the medication, do all the tests, and if you don't take the medication, you don't change how you think about your own health, don't participate. It'll unfortunately, these negative things can still occur. But medications and lifestyle modifications plays a big role. I can tell you, if you look at statin therapy, so statins are the mainstream medication for cholesterol. So just to give an example, there's atorvastatin, rosuvastatin. These came out in the mid-'80s or so. And prior to statin therapy, the mortality from cardiovascular disease was astonishingly high. The numbers that I just showed you are already astonishing. Can you imagine? They were 3 times than that. And it was just because there was no way that we didn't have anything that can modify that plaque. All we could do was wait till you had that plaque and it got to a point where there was no blood flow, then we can intervene. But since the statins and other cholesterol medication, we've seen folks who get into their 70s and 80s who have certain risk factors but actually never developed coronary arteries because they've maintained, a good control of their diabetes, good control of their blood pressure and their cholesterol. So, the data, is there, which shows that we can modify these risks. I can't modify your genetics. I wish you could, to say, hey, let's take out this vascular disease part, but we can't. But there are things that we can do that will decrease your chances of having a vascular event, or at least defer it. Again, all of us, one day, will happen to all of us. But the goal is to push this back as far as we can, okay? All right, and then of course, in some folks, when we get to a point where, the disease has progressed to the severe range, the blockages are multiple, or over that 70%, they're symptomatic, and, we're on the right medication, but things are just not getting better for them, we do revascularize. And revascularization basically means that we go in one way or another, we open that blockage up. So we can go on to the next slide for me. So this is kind of my area of expertise, which is endovascular interventions, where, again, we don't do this. This is without needing open surgery. And so we go in, we find out where the blockage is, and then we can go in and repair it. So essentially, we look at the heart under a fluoroscopy, which is just a sophisticated X-ray. We inject a little bit of dye into the blood vessels, so I find, okay, well, here's the blockage. And what we do is we put a wire, a very thin wire, into the vessel, and we introduce a balloon which has a stent on top of it. If you can imagine a stent, it actually looks nothing special. It looks like a spring inside of a pen. And if the blood vessel is blocked, we go in and we open it up, and then we leave the stent, as you can see, and the stent acts like scaffolding to keep that vessel open. We don't actually take out the plaque. There's ways we can do that, but most of the time we just simply open it up so you have good flow. The most important thing you have to remember with the stentings are that, with stenting is that this, if you have to get a stent either in the heart, legs, we can even do it in the neck and the brain, is that this is your friend for life. There's no way to take it out. Okay, so this, again, we don't do these lightly. It's only if someone needs it, but this becomes part of you for your life. It's nothing you can touch or feel. It's just something that you have to know that you have. And then you have to be on certain medication for some time to make sure the body heals around it. And we've done data that prior to the stents came out in the early 90s. Prior to that, we didn't have stents, and what we were doing was in folks who were having acute heart attacks, we would go in and just balloon it. So just with the balloon, go and open that vessel up. So but what we were seeing, the recurrent rates were very, very high. So that's when we realized that we have to leave something there so the vessel doesn't recoil or the plaque doesn't reform, because it's already, that area of the blood vessel is already very vulnerable. We can go to the next slide. And this, again, just to kind of give you more of a visual aid. So the thing where it says rotational burst, so we do have techniques where we can go in, if it's severe plaque buildup, which has calcium. So if you can imagine, you have a blood vessel that has calcium in it. It's basically a rock that's sitting there. So you can go in and try to balloon it, that rock is not gonna move. So even if you go put a stent in, it will not open up completely, so it really didn't serve its purpose. Now, we have tools which we can go in and actually modify the plaque, remove part of the plaque, and what that allows us to do is, get a smooth transition to basically have that stent go from a normal segment to a normal segment with normal flow, where it's not under-deployed. Because if there's a rock sitting there, it doesn't matter what we do. No balloon will fix that. So that's what that is, the rotational burst. It's basically just, we have a few different devices that can actually potentially remove the plaque. And it's not for everyone, it's only for certain people that need it, but it is out there. And if you can go to the next slide for me. Now, as advanced as we've gotten with the stenting, there is still an upper limit on our end as well, where if the disease is very, very severe, or if it involves the proximal parts of the blood vessels, meaning just at the beginning of the blood vessels, even from an endovascular standpoint, it becomes very, very high risk, because when we balloon, even for that millisecond, or we basically cut flow to the rest of the heart right there. So every vessel that we balloon, temporarily there's no flow. And in folks who have significant disease and who are particularly diabetic, sometimes stenting isn't the right option for them. And then we have open heart surgery. And basically, a bypass surgery is that we either take your own native veins from the legs, we can take one artery from the chest wall, and sometimes they even take their artery from the arms. And essentially, wherever the blockage is, the surgeon, this is open heart, of course, the surgeon is able to bypass those. The good thing with this is that they can bypass all the blockages at the same time. The bad thing is, this is open heart surgery. This is the big surgery. So again, we don't take any of this stuff lightly. So when we give you these recommendations, it is because the disease is that severe. Now, the biggest thing that I want to kind of get across to you guys, if you go to the next slide, please, is that this talk was just kind of, again, to give you kind of somewhat of an understanding of overall heart health, but the key here is prevention, and I think we can all do a pretty good job of preventing this. I'm not saying that it's a perfect system. This is what we have, though, right now. When you lose folks at a young age and you're not really sure why, you have to look at yourself, you have to look at your kids, you have to look at the rest of your family, and understand that when this runs in a family, unless you take an active surveillance role, and for these things can keep occurring. So again, just to reemphasize, the best way to manage cardiovascular disease, or any disease as a matter of fact, is prevention, and which just involves getting a regular, having annual physical or just a regular checkup. If you have high blood pressure, even if you don't have high blood pressure, you should at least get screening blood pressure checks to control that. Most importantly, if it was up to me, if I can put statins in the water supply, that's what I would do, because it is that important. If statin therapy has reduced cardiovascular disease by almost 50%, and it's just because when there's less of these lipids or these fatty acids to stick to the vessels, well, there's less likely to stick. Most, of course, there's modifying risks. There are things that we can't do much. If you have a genetic history or family history of having cardiovascular disease, I can't modify that. If you have high blood pressure, we can manage it, I can't cure it. If you have diabetes, we can manage it, I can't cure it. If you have high blood cholesterol, again, we can manage it, but I can't cure it. But there are things that you can do that you can actually get rid of that will modify your risk. The biggest thing is smoking. And it has to do with the thermal injury, it has to do with the chemicals, and it's shown where it causes so much stress on the blood vessels that it accelerates that. So now, can you imagine if you are someone who has a family predisposition to this, then you have risk factors such as high blood pressure, diabetes, and cholesterol, and on top of that, you smoke. So you took, a moderately bad situation and kind of made it a really bad situation because now you've accelerated everything. So from a lifestyle modification, even if you don't want to eat super healthy, which I still recommend, just stop smoking. And then, of course, exercise. We still recommend about 10,000 steps a day. Being cardiovascular activity, meaning you should get your heart rate. And the easy way to do this is so it's the number 220 minus your age. So whatever your age is minus that. Let's say we come up to 150. So 85% of 150 is around 130 or so. So to have cardiovascular activity, you should at least hit that heart rate. So as you can see, the older you are, the lower your heart rate needs to be to have that cardiovascular activity. The younger you are, you have to be more active to get that heart rate to where we need it to. So we should do that at least 3 to 4 times a week, about 30 minutes or so if you're able to. Of course, belly circumference has shown, so if you have a larger belly, again, if you're heavier, that is actually, there's been a direct correlation where they looked at, only thing they looked at was cardiovascular events, not just the heart, stroke, heart, as well as legs and belly size. And again, by no surprise, the bigger the belly, the more likely that person had some degree of cardiovascular disease. And eating a healthy diet, of course. Listen, here's my general kind of what I tell my patients: if it tastes good, you can't have it, all right? No, I'm just kidding, guys. No, that's not what. Again, I never tell anyone that you can't have this, because if I tell you right now you can never have ice cream, everyone's gonna want ice cream, right? And that's human nature, is that if anyone tells you you can't have this, that's what you want. So I never tell, I'm like, listen, have whatever you want, but it has to be in moderation, okay? The easiest way that I can tell you is that whatever weight you wanna be, pick the weight you like, that you're like, this is what I wanna be. You times that by 100. So if you wanna be 150 pounds, times that by 100, 1,500, that is your daily limit of caloric intake. So if you're like, listen, I wanna have some ice cream, well, understand that that's 500 calories that you're gonna have. It's okay to have it, but then you have to cut back on something else. And I think that's what's important, because there's a lot of diets we can all follow, and honestly, whatever works for you, but it really is that overall caloric intake. So the less calories you take, the less weight you will gain. That's all it is. Some of the diets that are fairly good are, the DASH diet, which is really good for people who have blood pressure. It's a low sodium diet. And then the Mediterranean diet, it's good in heart-healthy fats, particularly fish and omega-3s not only from seafood as well as from nuts. And then, I think it's easy to manage stress. I have no idea how to manage stress. I don't know. I'm sure maybe the pastor probably has a better idea than I do. But, if you can try to manage whatever stress level that you have, that'll always be very helpful. And I think that's kind of what I have for you guys at the moment. If you guys have any questions, I can take them now. If you guys want to talk about something more personal and individual, you guys can catch me after.
Thank you so much, Doctor, for the time. I've written a couple of questions.
Absolutely.
So this I'm talking on behalf of all the congregation, because Lord has given me the privilege to hear, individual stories. what is the direct relationship between stress and heart health?
So again, it's a large question. So when you have high degrees of stress, what we notice that, and from a physical standpoint, is there's a particular enzyme that's released by our body. It's called cortisol. Those of you who want to look at cortisol is released from our adrenal glands, and it's what we call a stress hormone. So meaning when you are under mental or physical stress, mostly more mental stress, you have a higher level of cortisol. And cortisol has been shown to make the body retain fat. So basically, higher cortisol level, more likely you're going to be heavier. Okay. And based on what I just said, the heavier you are, then of course all these things can happen.
Yeah, unfortunately, we have large circumference. One of our congregants recently had this grade 1 systolic or diastolic dysfunction. Any light on that one?
Yes. So that is something that we become the echocardiogram. That's the ultrasound that we do of the heart. So there are two things that the heart has to do, and very simply put. One is it has to pump the blood out of itself to the body and to the lungs. But before it can pump the blood, it has to relax to allow the blood to come back to it. And diastolic dysfunction is where the heart gets a little bit stiff, meaning it's not able to relax as much. So it's not able to receive the blood back. Grade 1 diastolic dysfunction it's very common. It is actually equivocal to, as we get older, it's just the muscle just it doesn't have that recoil anymore, and it doesn't generally cause any issues. Once you get to grade 2 and grade 3, that's when you start getting some symptoms from it. And the most common symptom from that is shortness of breath, edema, swelling of the legs, but the common cause, or at least right now, the most common cause of diastolic dysfunction is uncontrolled blood pressure. So if you control your blood pressure, you will reduce your risk of having diastolic dysfunction.
Yeah. The ejection fraction that you mentioned, in this, the echo test will give you that. When we should be worried? I know, from 55 to 70, there is quite a bit of range for the ejection fraction. Many of us get the test also. Yeah, so when to actually worry about that ejection fraction and the number?
So from basically if it's under 50, for men it's 52% and over is normal, and for women 54%. They did some average and that's what they came out with. So generally speaking, if your LVEF or the systolic function is more than 50%, that's still considered normal. And as the pastor was saying, there's a big range in that. Normal could be anywhere from 50 to 70, and once it gets down below 40, that's when we started calling it cardiomyopathy, and we do have to put you on some sort of medications. Things that can make your heart function, something like, oh, how come you had 70 and I only had 55? Actually, if you're a little dehydrated, your heart just beats a little bit faster. So at the time of the echocardiogram, if you just didn't have enough water in your system, it just makes it seem like it's going, your EF's a little bit more, but it doesn't mean anything, clinically speaking.
And now, again, one of the congregants recently was talked about cardiomegaly. What is this?
So cardiomegaly, literally, if you translate, it's in Latin. It all just means is cardiomeg. Meg just means big, so the heart's gotten bigger, and that basically happens when the heart function is reduced. And if you can imagine, the blood is not going anywhere, okay, but the heart is not able to pump it, so the heart basically just gets larger and larger to compensate for that blood that it's not able to move.
So it's enlarged.
Correct. That's not a good thing for the heart.
Oh, okay.
You don't want the heart too big. From a spiritual heart, you want a big heart. Physical, you don't want a big heart.
Yeah. Statins, as you said, you're going to pump statins into the water and everywhere. Is there any, the diet-wise, where we can get more statins instead of medication?
Dietary-wise, the biggest thing is omega-3s, so fish, mostly from fish, and then, omega-3s from DHA and EPA. Those are plant-based omega-3s. Mm-hmm. So that has shown to reduce your cholesterol. Red rice yeast has shown. But again, it's the less, if you just intake less fat, then you're less likely to have cholesterol. Now, cholesterol mainly, it's kind of interesting, is cholesterol mainly comes from meat. So, red meat, pork has higher cholesterol content. So if you have, when they say leaner meats, that is basically a lower cholesterol. It's not saying it doesn't have any, it's just lower than the other ones. And then stuff like milk and ghee, it's not good, of course. I mean, it tastes great, but there's cholesterol in that because there's fat there.
Yeah. But people nowadays are following this, the paleo diet or something like that. Yeah, where the mid-chain fats like ghee and coconut oil.
Correct.
What do you talk
So
about?
that's fine, but again, so the way that paleo works is actually similar to keto, so your body needs some degree of energy, and the fastest thing that your body can break down, so we get energy, is carbohydrates. Carbohydrates include stuff like bread, rice, all the stuff that tastes good. That's carbohydrates. Then there's fat. Fat comes from, meat, dairy, cheeses and all that. And then there's protein, which comes from meat. So what the paleo and the keto diet are trying to do is they completely either exclude or reduce your carbohydrates. So instead of using carbohydrates for energy, your body will use the fat. And the data on that is pretty good. People lose weight, they get healthier. In some folks, you can get a little bit of buildup of fat in the liver because you're having so much fat. So if that's something you want to do, it's okay to do so, but you basically have to you have to exclude all carbohydrates. And I would do it in short blasts. So, do it for 4 to 6 weeks, then go back to normal. Do it maybe 2 or 3 times a year because it does make a big difference on weight loss. But it's a very odd way to do it because you can have all the food you want. There's no limitation, but it's got to be all protein and all fat. So no carbs.
One cardiologist, Dr. Loam, he said, going for a paleo diet. Paleo diet is popular in most of us now, eating only protein, no carbs, and taking that power coffee, black coffee with coconut oil or ghee. Yeah. But he said that there is a statistic saying that 60% of the people who follow the paleo or this kind of diets are getting high lipids, high cholesterol.
Correct. So again, and he's not wrong in that, but there's a bit of a different, so just having high lipids, there are different kinds of lipids. And the one that causes the actual plaque is LDL, but we have other forms of lipids, which it's actually called non-HDL, and it's just a category where we're not actually sure what it does, but all we can tell you that medically it's not significant. So because you're intaking so much fat, you have these higher elevated levels of lipids, but they're not causing any clinical symptoms or increasing your risk of cardiovascular disease. So he's right, with the blood work is abnormal, but it doesn't really translate to any significant disease.
And in your talk, doctor, I heard a lot about diabetes. Diabetes, and the Caucasians here, they eat 10 times more sugar. And we, unfortunately, we eat pickles and spicy food, and we get more into the diabetes thing. I mean, why so is a very bad question, but diabetes, direct relationship to the heart health.
Correct. I mean, diabetes is genetic. I mean, there is a form called it's a type 1 where, if you get an infection when you were very, very young, the kids can get it, but that's not the common one. Mostly it's a genetic thing which we get as we get older. There's a direct correlation. If you're heavier, you're more likely to get diabetes, even if you have a genetic component to it. So say if you have a family history of diabetes and you're 250 pounds, well, you will likely get it at a younger age, but you're the same person and you were 150 pounds, you'll probably get it, but later in life. So later in life, less likely of complications. Now, it's direct correlation with heart health. Diabetes is the number 2, I guess, leading cause of cardiovascular disease. And basically what it does is when the blood sugars are high, it stresses the arteries. It causes micro trauma, micro injury. And it doesn't do that just in the heart, it does that everywhere. And so if your blood sugars are staying higher, because this vascular injury keeps reoccurring, the buildup of that plaque is accelerated. So again, it's not that we're not going to all of us will get some degree of blockages, but if you have diabetes which is not well controlled, there's folks who are walking with A1Cs of 13 and 14. Well, listen, that person is going to get those blockages built up in years rather than decades. So that's where the correlation comes in.
So acceleration of the cardiovascular disease if there is a diabetic. Okay. And any questions? I'm asking all the questions. If anybody has anything. Yeah.
Hello, brother. What kind of tests, like, is there doctor can suggest to the people start from the scratch to cover the full health of the heart?
Got it. So yeah, I mean, again, there's basic labs, which is the blood work I mentioned, which is just to kind of get an understanding of where you are today. So your blood counts, your liver function, kidney function, an EKG. Sorry, I should have actually mentioned that, which is something simple that we do in the office, and that just shows if are there any abnormalities just on a very basic test. And then we do, this is something we do. So just basic blood work, EKG, and then you talk to us. And you tell us, we will ask you the questions and figure out where you fall in something called a cardiovascular risk score. And based on where you fall in that, we would determine if we need further testing. If you have symptoms such as chest pain, shortness of breath, which have, particularly if you're saying, hey, it gets worse when I am physically active, then in addition to the testing I already mentioned, we may opt to do a stress test.
Doctor, there is one, again, recently one of our congregants, 70-year-old, congregants' parents actually in India, 70-year-old, he just, fainted for high diabetic and hypertension. He fainted. Instead of doing the regular echo and the stress, they straight away did the angiogram. Is it?
Correct. Yeah, we do that many times. I mean, if you look at an individual person and their risk is very, very high, if an echo, I'm certain they probably would have done an echo because so if someone comes in the middle of the night, and I'd have to go in the middle of the night if someone comes with a heart attack, it's a timing thing. We need to get in there and open that blood vessel as soon as we can to save that or preserve that heart muscle. So yes, then the first thing we do is the angiogram because you are actually having a heart attack.
Oh, okay.
So then you don't want to do a stress test because if someone has all the right symptoms, actually doing the stress test can cause them to have a heart attack. So you want to move directly to, what we do is a pre-test probability. If your pre-test probability is high for having underlying obstructive CAD, you can move right onto the angiogram. But you still do an echo, usually just a little bit later, just because we need to preserve the function.
Okay.
That's all.
Yeah.
So I also have a question, two questions actually. First thing is I heard somewhere about dental, choices that you make with your dental stuff. So getting a root canal or certain things also can affect your heart. So that's my first question. And the second question is, what are your thoughts on black coffee, drinking black coffee in relation to heart health?
Okay. Well, how about I answer the black coffee first? So I love black coffee. So there's been really no data on black coffee adversely affecting the heart at all. I think there's always you can have some GI symptoms, like heartburn and gastritis if you have a lot of black coffee, but it doesn't really hinder or have any really effect on the heart from a vascular standpoint. However, coffee is an upper, so meaning it makes your body, this is why we wake up from it. So if some folks have underlying arrhythmias, like AFib or SVT, it can cause issues on that side, but not from a vascular standpoint. Now then there's folks who say they drink coffee, but they basically drink sugared milk. It's because, well, you have tons of milk and tons of sugar. Well, that's different because now that's just a caloric thing. So does that answer? Okay. And then dental stuff. So that is a bit different. Now, there's been some data that suggested, and it's kind of interesting, is that if you're someone who has dental plaque that builds up, well, it's the same plaque that builds up on your teeth, which builds up in the coronary. So if you have, if you're someone who needs cleanings more frequently or built up, well, that actually there's been some data that suggests that actually increases your risk of underlying cardiovascular disease, but it makes sense because if you're having built up here, you're having it in the body as well. Now, as far as having root canals and dental work and stuff, that doesn't apply for all of us. That, you can have whatever you want, whatever procedure you need with your teeth. It doesn't hinder your heart health or anything. However, there are folks who have had either artificial valves placed, or have had an artificial heart, or some sort of transplant in their body. It's when they get root canals or any kind of dental work, there's bleeding involved, and you know, our mouth has a lot of bacteria, so the bacteria sometimes can get into the bloodstream, and it can go and cause an infection on the artificial device that we have in our body. It's only for those folks where the dentist has to talk to us before we do anything, and usually we just put them on antibiotics. But, you know, saying that you just need a root canal, yeah, that doesn't do anything bad to your heart.
Oh, one more question. So we do have a preventive test that we take every year, right? Like for the regular blood tests and everything. Would that cover the heart part also, or is there some preventive test every year that we can take for the heart?
I mean, again, I think some of it is, it's an individual thing. If you do have to look at your family history. If your family history is not very, very high for vascular disease, well, that's a good thing for you, you know, for that individual person. But yes, including the basic kind of physical exam and blood work annually, one is whether you have symptoms or not. If you're asymptomatic, then, you know, there's not much we really need to do. You can add on this coronary calcium score, which basically is, it's a very simple CAT scan, and it's just more peace of mind for you, is where if you look and you see your calcium score is very low and you have no symptoms and you're at average risk for vascular disease, your individual likelihood of something bad happening is low. Now, let's say that you're the same person and you have some symptoms, something where you're like, yeah, you know, when I go up the stairs, I get a little short-winded, I get a little chest pain. Yes, then definitely stress test. So the short answer to it is that there really isn't. You have to individualize the care. And that's why you have to talk to your doc essentially every year. Hey, do you still feel the same? Yeah, you're still as active. You know, there's some degree of, as we get older, you know, we're not able to do things because our hip hurts or the knee hurts, but it shouldn't be where, hey, I can't go up the stairs anymore because, you know, I get really short-winded. That's different. That's very, very different. So it's really these cues that we have to, and you have to be honest with yourself, like, is something different with me?
Thank you.
If there is no symptom at all, I think the family history, as doctor was mentioning, that should trigger us the annual screening if there is a family history.
So, you know, for example, to use the pastor as an example, because there's a family history here, yes, he automatically is someone, you can't say that he's low risk, right? He automatically falls in this intermediate risk. And he's likely gonna stay in the intermediate risk for the rest of his life just because of that family history. And as we get older, well, that risk just keeps getting higher. So in him, I'm sure Dr. Shah is keeping a close eye on his heart. And again, this is where when you go to your primary or when you go to your cardiologist, you have to individualize that care. And that's all it is.
Yeah, there is family history. And so is there an age limit where I can take the preventive?
Nope.
Thank you.
The sooner you start, I'll give you an example, and by no means am I promoting this. This is just me personally. Of course, I'm Indian too, so the risk of vascular disease is there. You know, I don't have terrible habits. You know, I don't smoke or anything like that, and I think I generally eat fairly healthy. But I looked at my own, and I'm like, well, I'm doing this. I should probably practice what I preach. I looked at my own cholesterol panel, and my LDL was like 130. And I'm like, man, I was pretty young, and I was 31. So I started taking a statin. I've been taking a statin for 5 years now, and my cholesterol is well below. And I don't know what the data, I mean, there's really no data on young folks like me. You know, it's like, even the ACC recommends you don't necessarily have to start it, but as someone who's doing this for a living, you know, I'm like, why would I not reduce the amount of this stuff in my body? You know, that's all.
Yeah, as you mentioned, 29-year-old was one of his patients. So age doesn't matter, and from 5 there will be the build-up. So for us, it is a good idea. If there is a family history, get it checked.
And trust me, in Indians, there's a family history. They just don't tell you.
Yeah, Sunil.
Yeah, hi, doctor. So I have two questions. Like, one is like, how can we differentiate the chest pain, whether it is a heart attack or it is a muscular pain? So Because most of the cases myself, I feel like a lot of time paining, but I couldn't able to differentiate like where it is weird. Like I went to the doctor, my physician. Most of the time I did the ECG also. So she mentioned that nothing is there, so your heart beats, everything is good. But I feel when I come home, when I was with the doctor, I didn't feel anything pain. But after coming back home, I will feel that one. So I don't know like why it is happening. The other one is like one of my fellow brother. There was a like normal exercise.
I'm sorry, I can't hear you. I don't.
Okay, sorry. There was a normal exercise like normal cardiac. What is the basic exercise he was doing, but suddenly he collapsed and he died. Okay. So how can we like either prevent or how can we identify those kind of things?
Well, I'll answer your first question. So the way we differentiate chest pain, we've kind of got, we do three things. We will classify as typical chest pain. Typical chest pain means that based on what you're telling us, this is coming from the heart. Non-cardiac chest pain is based on what you're telling me, this is not the heart. And then there's a middle ground, which is called atypical chest pain. Unfortunately, vast majority of the time, patients fall in this atypical chest pain symptom. So cardiac chest pain is not something that's constant. Cardiac chest pain is usually exercise-inducing, meaning when you are physically doing something active, which could be walking, going up stairs, or just doing work around the house, and you get you get chest pressure, discomfort, and when you sit down and you relax, the chest pain goes away. That's very concerning for cardiac pain. If you're telling me like, hey, I get this chest pain when I ate this particular food, or well, when I move my arm this way, I get the chest pain. That's not cardiac chest pain. Because you can have, there's other triggers for it. Unfortunately, a lot of times when you fall in this atypical, they're like, well, I do get some chest pain when I do some physical activity, but also when I move. Then the way you differentiate is you have to do more testing. And that testing is the stress test.
A follow-up question on that one, doctor. During this pandemic period, a lot of people have this panic attacks, the stress things. Which caused the pain in the chest?
So there is, from a cardiac standpoint, you're getting pain because there's decreased blood flow to the muscle, and the muscles, that's how the heart tells the brain there's something going on. From a panic attack, or when it's more of a stress-induced thing, it's mostly just because the heart's beating very, very fast. Okay. And you just have that sensation. Of course, when you have, when you're in a physically stressful state, everything in your body starts being a little bit fast, and you also get some degree of kind of reflux. You're breathing shallower. So that pain is more so from just everything going very fast.
Okay, yeah.
I'm sorry, you had one other question? The sudden, yeah. So, I wish I can tell you, and I wish there was a right answer for that, and I think there really isn't. It's just that, there are even people under our care where we've done testing on them, non-invasive testing, and then something bad happens, and like on paper they look perfect. That is a rare thing, and I would say vast majority of the time there are some signs that are saying that, hey, there may be something going on. It may be a little bit somewhat subtle, but no, if someone, if the first symptom is an MI, which is very large and that can lead to death, there's really no way to unfortunately prevent that. Although it's rare, but when it happens to your loved one, it's not rare. But generally speaking, that's a rare thing, and even we don't have a really good answer for that for you. Hi.
As per World Health Organization, unofficial death is more than 15 million so far. And in this percentage, how many heart patients might have died? Because this COVID is hitting every organ.
Oh, understood. I'm sorry, I misunderstood. Okay. That's a tough one. And the reason is, the data is still so convoluted, and even it all depends on which chain of thought you want to follow. But I think to basically keep it simple is that when COVID was predominantly a pulmonary disease, basically it caused a very, very severe pneumonia. And when that happens, the heart and lungs are codependent. When the pressures or the lungs have to work very, very hard, then the back pressure will affect the heart as well. So, if you were someone who was vulnerable, what that means is someone who's older, who has risk factors, which include the medical problems we mentioned, or who's had prior heart attacks, prior MIs. So you are already at a predisposition of having something bad happen, unfortunately, and then you add on this very severe acute infection. And to be honest with you, it could be COVID, it could be the flu, it could be anything. It doesn't matter. Whatever, if that infection is severe enough, because it stresses the heart more, the demand, and there's a supply and demand mismatch, you can have an event. And then there was some data that suggested that the COVID infection particularly made you more thrombogenic, more likely to have clots. So obviously, if you have a clot in the blood vessel, that increases your chance of having a heart attack. So I think it's a combination of those two, where the COVID infection made you more thrombogenic, and then there was a lot of stress on the heart from just having an infection. But it's not just COVID. That's true of any kind of infection. Even prior to COVID, people were unfortunately passing away from just the flu. So I think that, what percentage of that is from the heart? I mean, we always say that eventually when we say someone's passed, it's because the heart stops. So, it's always a cardiopulmonary arrest. So I would say vast majority of the 15 million is the cardiopulmonary arrest, ultimately speaking.
Relatives or in India, they say cardiac arrest. That's the cause of death. Thank you.
Rajni. Yeah. We'll take last couple questions for 5 more minutes and we'll close. Yeah. We know his age now. He's 31, so he's young. He can take. Thank you. Thank you so much, doctor.
Hello, doctor. If a teenager like 18 to 20, if they have high LDLs, how do you maintain? Do you recommend statin therapy for them also, or we should ask the pediatrician?
How high is the LDL?
I don't remember.
It does depend on. I mean, again, usually at that age, I would be hesitant on starting anything, and I think we would definitely, if they're heavier or if they're not very physically active, I would encourage that before starting medication, and then repeating some testing. Also depends on family history. What's their family history of vascular issues. There is a form of there's something called hypertriglyceridemia or familiar hyperlipidemia, where there's a genetic component of having high cholesterol. And that's something you're born with. And if that's the case, there's some blood tests we do to see if they have that. And then, yes, you would treat, because that particular gene has shown to increase your chance of having MI or heart attack or stroke at a young age. But if it's just mildly elevated and they're not very active or a bit heavier, I would more focus on lifestyle in a young person rather than starting medications.
Can you enlighten on transient ischemic attacks? Like how TIA? Transient ischemic attacks?
Oh God, I'm sorry. So a TIA is basically a stroke or a pre-stroke. Basically, there's symptoms that you have when you have a stroke, and most commonly, as people say, they get numbness or tingling on one side. They get weakness on one side of their body. The mouth may feel it gets drooping. They may lose vision in one of the eyes. And if it's permanent or persistent, that's a stroke. In some folks, you can have what we call a TIA, which is those exact symptoms, but they resolve. And in 24 hours, you're back to normal. That's a TIA. It is a stroke, but it's small. So your body's able to you didn't lose too much of your brain tissue or very minimal, and your body, you didn't lose anything permanent. So a TIA is a stroke that's transient, and it's basically your body telling you need to do something before you actually get a stroke.
Thank you.
I mean, again, sometimes it gets challenging, but typically, like I said, cardiac chest pain is induced with exercise. So when you're physically active, when you're doing something more where it requires more cardiac output, that's more cardiac chest pain. If you say hey, I get this chest pain after I eat and I go lay down, that's at least based on that, it sounds more like it's non-cardiac chest pain. But again, then you look at things like family history, then you look at your EKG, you look at basic blood work. If you're like, well, I've had this chest pain, it's bothering me, well, then we do a little bit of testing. We do an echocardiogram, maybe do a stress test. but based on, generally speaking, cardiac chest pain is short-lived and usually comes on with exercise, resolves with rest. Now, if you have true cardiac chest pain, which is constant, that basically means that you have very severe disease. Generally speaking, in younger folks, that's not the case. And if you can associate the pain with certain kind of food, it's again more pointing towards GI.
Can we say that gastric pain will not have the cold sweat, whereas the cardiac, no? So, okay.
So that's why, again, if you have some sort of chest discomfort, it's reasonable to, my theory in this is that I would rather know what it is than just say maybe. I want to know for sure.
Yeah.
That's all. And these tests are not they're relatively benign tests. Vast majority in folks who are under 50, we just get you on a treadmill, and just to make sure we're not missing anything. And it gives you peace of mind, it gives your family peace of mind, and it gives us peace of mind that, hey, he's going to be, or he or she's going to be fine. So typically, left shoulder, left arm pain has been associated with chest because just the proximity and the way the nerves intervene. Again, if it's more right-sided or neck or back pain, that not so much. But again, I'm not trying to be coy or anything. It's sometimes even for us when we're listening to the story, I'm like, I'm not sure. It could be, and that's where the testing comes in. Yes.
Yeah, Sunil.
Why do we need to check our
Heart.
Oh, well, come on now. You have to give it to a young lady one day, right? I don't know if you got that one. Sorry. All right. Well, the heart is what pumps all the blood around the body, right? So in order for us to function and be who we are, we need oxygenated blood to go to everywhere, from our eyes to our toes to our fingertips, and it is the heart that pumps it. So if the heart is not able to do its job because it's not getting enough nutrition or blood, well, then you are going to have dysfunction the rest of your body as well.
Yeah. Hi, doctor. Sorry for the multiple questions. One more question left actually. Being a blood pressure patient.
Being a what?
Hypertension.
Patient. Any suggestions on the exercise? My wife, when I ask for exercise, right, she usually scares about when we do the exercise, basic cardio also, it may lead to heart attack, something like that. So do you have any suggestions or any guidelines on that?
Right, okay. I just want to make sure I clarify your question. The question is that because you have high blood pressure, if you exercise, you can induce a heart attack? Is that what you're asking? Got it, okay. The short answer is yes, but just because you have high blood pressure doesn't mean that you have vascular disease. So first, you should just be, in general, you want to be active. And, again, if you're younger, your risk of having significant underlying disease is low. But if you're very concerned, the reason is, are you concerned because when you start exercising, you start feeling short of breath and chest pain? If that's the case, well, then you come see one of us, and we do stress tests, and we prove to you, hey, there's nothing wrong, it's fine. Then but again, if you are deconditioned, meaning if you're someone who doesn't exercise, you're not very active, well, that physical activity of doing something is going to stress out your muscles. So you may get chest discomfort just because the muscles are tense. And those of you who, if you go to the gym, the initial, when you start working out, when you do your biceps and stuff, the first time you do it, your arms are going to hurt for a week. It's because they're not used to working out. So even if you have some symptoms such as chest pain and shortness of breath when you just started working out, it may, even though, of course, you can't exclude underlying disease, but if you're younger, no significant family history, and your blood pressure is well controlled, the likelihood that you have that pain is from from the cardiovascular system is low. It's just more likely that you just haven't done it before. So that's all. Yes.
Hello, doctor. I have a couple of questions. This is mainly related to heart, not the blood vessels. You mentioned that other than nicotine, that there are other things in tobacco or those products. So what are those that will lead to hypertension and then cardiac heart issues?
So sorry, I missed that.
Oh, you said that other than nicotine, the other things can cause vascular damage.
Correct.
So what are those other things?
Oh, I have no idea.
Okay.
Oh, sorry. It's
So,
whatever, like,
no.
the chemicals that are in the cigarettes. I mean, I know tar is what links some into the actual lungs. Whatever the other chemicals that they have. I mean, they're basically so cigarette smoking causes your vessels to constrict, whatever those chemicals are.
Okay. So my question is mainly about cardiomyopathy, and I'm a nursing instructor, so I taught patho. So if your answers are more at patho level, I can understand. I think, would you say that diabetes and hypertension and CAD could lead to cardiomyopathy?
Say that one more time. Sorry.
I would say diabetes and
Diabetes,
coronary artery disease. Could they lead to cardiomyopathy?
Oh, absolutely. So cardiomyopathy, cardiomyopathy just basically means that the heart muscle is weak.
Right.
Okay. So when someone has a weak heart muscle, there's a fork in the road that we have to differentiate right away. Is this cardiomyopathy because someone has coronary artery disease because the heart itself is not getting enough blood flow, thus oxygen? That's one category. And then there's another category, which is basically, we don't know why the heart's weak. I can give you some theories, but it's not a flow issue. Most commonly in this country, it's uncontrolled high blood pressure, it's drinking,
Right.
and infections. So just because you have coronary artery disease does not mean you have cardiomyopathy.
Right.
And just because you have cardiomyopathy does not mean you have coronary disease. But vast majority of the time they do play, people who have coronary disease will have some degree of cardiomyopathy. And the diabetes plays a role because that predisposes you to get coronary artery disease.
Right. What is the prognosis for cardiomyopathy?
It depends. What's the heart function?
So one last question related to that is, we have so much going on with vaccine, COVID vaccine and cardiomyopathy. So how would you? I don't really, being in medicine, obviously I would at least say I'm not anti-science, or I can only tell you the data that's out there. Sure.
Okay, by no means I'm not an immunologist, and I'm not a vaccine person, or like who develops them. But the stuff that people are concerned about with the COVID vaccine is actually stuff that's not new for COVID vaccine. This is true. People have had this discussion 10 years ago about vaccinating their children. So there's nothing different about the COVID vaccine versus, measles and mumps. It's the same kind of principle of it. The COVID vaccine was actually formulated on the flu vaccine. So meaning they took the flu vaccine, modified it, and then they were able to do, at least that was the Pfizer one. I'm not too sure about the Moderna. But it's something similar. So they took a shell that was already there, and they modified it to the RNA of the COVID virus. So yes, can you see some increased risk of blood clots or some cardiomyopathy or some bad things with the vaccine? Yes, at least that's what we're seeing data-wise, but it's not necessarily just linked with the COVID vaccine, that's linked with vaccines in general. And that can happen from anything.
When we go to a naturopath, they'll say, don't take vaccines at all. So, don't take vaccines at all. No vaccines at all. But naturopaths, not naturopaths. So, no, that's, again, science is different.
I think for that is just, it's your, again, if you look back, if you look at our grandparents, like people back home were dying from measles and mumps, right? That's gone now, and partly because of the vaccine. There was a huge thing with polio back home. I remember when I was there, you would see these kids who have physical deformities from polio, which is such a simple childhood disease that we can manage, and now they're stuck with this for the rest of their lives. And I'm not overplaying the vaccines. Ultimately, it's your decision. It's your decision for you, your family, but you have to look at the data that says that, hey, all these vaccines back in the past, have taken away this disease. The data that suggests, vaccines are linked to, some sort of neurologic issue. There was, at one point, there was concern, it's causing Asperger's, and now with the COVID vaccine, it was increasing chance of cardiomyopathy or blood clots. The other chain of that is that all it did was unmask it. You were gonna get that anyways, because you happen to have the vaccine, it just unmasked it. I'm not saying that's the correct answer, but that's just kind of what we're seeing. But ultimately, it's your decision on that.
are there any other lifestyle modification would you recommend for this cardiomyopathy?
I mean, lifestyle modification for cardiomyopathy is make sure you take all your medications. If your LVEF is less than 35%, you should probably have a device, the ICD device. And the biggest thing for cardiomyopathy is making sure your fluid levels are good. Okay, so meaning you have to be mindful that either you have to be on medication that helps expel some of the fluid, and you have to monitor how much fluid you intake. You want, and generally speaking, from a fluid standpoint and a blood pressure standpoint, you don't want to have more than 2 grams of sodium a day. Okay, so kind of cut back basically on your salt. So if your salt intake is good, your fluids are restricted, you take all of your heart failure medications, and your EF is less than 35%, you have that device, your likelihood of mortality from cardiomyopathy is the same as someone who doesn't have cardiomyopathy. So cardiomyopathy is heart failure. It is heart failure. It's basically, again, there's cardiomyopathy, CHF, systolic CHF, low EF. They all mean the same thing. It's just different. They're all synonyms. Typically, when we say heart failure, it's someone who has cardiomyopathy and they're acutely volume overloaded, meaning they are in a stage where they're not doing too well. So they wind up getting at the hospital. So when we say heart failure, that's usually what we're saying. But if you control your cardiomyopathy, you want to stay out of that heart failure state where you've gone to the point where the heart has been overwhelmed.
I'll take one last question, I think. Doctor, thank you so much once again for your patience. We all eat masala food.
That's good.
Right? Which cause some kind of a gastric issues and stuff. Is there any direct relationship between the reflux gastritis and carditis? We didn't talk about carditis. Pericarditis.
Pericarditis, I'm so sorry.
Yes.
Got it.
Yeah.
No. So again, there's always this risk. No. So certain foods, they don't really impact your heart in any way. Pericarditis is a very, very rare thing. It usually occurs either post-operatively or in young folks who have a really bad infection. And no, your dietary intake, masala, spices do not impact your cardiac anatomy or vasculature in any way. So that definitely I can tell you. Please feel free to eat your spices.
So I like this doctor. We can eat masala food, but one thing that he said is Mediterranean food is actually very good for heart. My favorite food. So that's my, listen to doctor now. She won't allow me to take that food.
Well, I said Mediterranean diet. It's a little bit different, right?
Yeah, large circumference. But one thing is that, anything, the build-up begins at the age 5. There is one big takeaway for all of us. We need to take that into consideration, family history, if there is any. Recently, Rush promoted something for the calcium score. It is, without your insurance, they charge some $79 or something.
Yeah, like $50 or $80, something like that.
Yeah, and some of us utilized that one just to get the calcium score. It is like opening and seeing, okay, everything is okay, no rust, kind of a test. I think it is still there.
It's still there.
It is still there, yeah. Maybe that is one test. Rakesh was asking about that one. Yeah, that calcium score will give, okay, something is okay, something is not okay. A preliminary test. It is some $69 or something without insurance. I did Sunitha took, and some of our brothers and sisters in the church took that one. There is a promotion still going on with the Rush. Again, I'm not promoting Rush, but that's a test that is available there. We'll close now, once again. On behalf of all of us and the viewers online, I really want to thank you, Doctor. Thank you for your time. A very big hand, very big hand. Yeah. Sister Mary, she patiently came and she's taking care of the baby, yes. Joshua, and they're expecting another child, so she's carrying and taking care of the baby. I really appreciate even she joining us today. She's not here, but yeah, she can see that one. Yeah. And I asked one final thing. I asked how much would it charge to bring doctor here and to educate our congregation. They said, no, not a penny. For that, we'll give one big hand. But seriously, we all need some kind of an education. Stress is very important thing for us to handle. At the same time, just being a South Asian increases our, risk. As a doctor was telling, just being of Indian origin increases. Yeah, this gore log, these white people, they eat 11 kilos of sugar on average per year, and we eat only 1 kilo. Still, we get too many, diabetes and heart issues and stuff like that. Well, they have their share, different things. We have our share, different things. Yeah, but again, our body is the temple of the living God. Prevention is always better than cure. Believe me, when I'm in the curing stage now, it is very difficult. In the preventive stage, I thought I was young and strong, and even though there is a family history, I didn't take care. So prevention, if you have somebody in your family that has some kind of a heart issue, as doctor said, most of us have, so it is very good to get annual checkups or some kind of a, going towards that direction and taking care of things first before it hit any kind of symptomatic issues. So prevention is always better than, always better than any kind of a medication. We can take care of that one. Yeah, we are all young, so yeah, I'm young too. Yeah, we can take care of all these things beforehand. Yeah, once again, thank you so much, doctor, for your time. Yeah, stay with us if you can have a bit lunch with us. And if there are any personal questions, you can meet doctor. Thank you so much.